Hello, everybody, and welcome to today's Grand Rounds, which is part of our George Engel Research Round Series. My name is Steve Silverstein, and I'm the Associate Chair for Research in the Department of Psychiatry. Today's presentation is by an Assistant Professor of Psychiatry in our department, Lisham Ashrafioun. And the title is Addressing Loneliness in Individuals with Substance Use Disorders. Before we get to the presentation, though, I just want to mention a few reminders. First, everybody's camera is off and everyone's microphone is off as well for the remainder of the session. Also, please do not put messages in the chat box. That's reserved for the panelists and the interpreters in case they need to communicate quickly with each other. If you have any questions, which we hope you do, please put them in the Q&A box. And near the end of the presentation, I will read the questions to Dr. Ashrafioun, and we'll get through as many as we can. Also, at the end, there'll be a link posted for the evaluation of the session, and that will be posted in the chat box as well as on a slide at the very end. And then tomorrow, an email will come out with that as well. So please complete the post-session evaluation either today or tomorrow. All right, so for today, as I mentioned, Dr. Lisham Ashrafioun is our presenter. He's an assistant professor here in psychiatry, and he's heavily involved in the Center of Excellence for suicide research and prevention at the VA. And so, we'll hear from him, and then again, please put your questions in the Q&A box, and we'll see you on the other side of the presentation. Go ahead, please.
Okay, awesome. Thank you very much for that introduction, and you nailed the pronunciation of my name, so that's amazing. So I just want to thank everyone for attending. This is my second Grand Rounds I've done, the first one that I've done through Zoom, which is nice because I can have my shirt untucked. The downside is that my neighbor is cutting a tree, and so I have that lovely hum in the background. But honestly, I'm very excited because this will be the first one that I'm doing where I'm going to be able to discuss my first externally funded grant. And while I work primarily at the VA, my first externally funded grant ended up, being through the university. So I'm really just excited to talk to everyone about this ongoing clinical trial that we're doing out of the department that focuses on addressing loneliness among individuals with opioid use disorders. Unfortunately, won't be able to present on any of our outcome data, but I'll kind of take you through some of our work up into this point and what we have in store for the future. So again, the bulk of the work that I'm going to present on is an R21 that's funded by the National Institute on Drug Abuse, or NIDA. And then, other standard disclosures here. I don't have any conflicts of interest to disclose. So just overall, drug use is, clearly a huge public health concern. In some of the graphs that I'm about to show, unfortunately, the numbers on the y-axis have just seemed to get higher and higher over time. It sort of demonstrates this this sharp rise in drug-involved deaths from 1999 to 2020. You can see that they've, increased nearly fivefold. And unfortunately, the estimated number of drug overdoses from October 2020 to October 2021 was over 105,000, representing an additional 15% increase from there. And so what we find is that opioids in particular, especially with the sharp rises in synthetic opioids like fentanyl and its analogs, are driving sort of these wild increases. And so over 68,000 of the 95,000 overdoses involved in opioid. And then we're also seeing some fairly sharp increases in deaths involving stimulants like methamphetamine and cocaine, which are often used in conjunction with opioids. And then, of course, working at the VA Center of Excellence for Suicide Prevention and U of R's Center for the Study and Prevention of Suicide, how could I also not mention that opioid-involved suicides have also climbed dramatically. And likely many of the unintentional overdoses are misclassified suicides as well. So there's been, of course, a strong push towards addressing that epidemic. So some examples include things like increasing access to evidence-based treatments like medications for opioid use disorders, increasing opioid overdose education and naloxone distribution to reverse opioid overdoses and to educate people about how to prevent overdoses. There's been increased surveillance of prescription opioids or adverse outcomes associated with opioids, and increased access to non-pharmacological pain treatments, just to name a few. Now, there's been noticeably fewer efforts that have looked into addressing transdiagnostic psychosocial factors like loneliness. So what is loneliness and why is it important? And so we think of loneliness as a subjective emotional state that's characterized by the perception of social isolation. So it's related but distinct from objective social isolation. So you can imagine someone with few social contacts, may not be lonely, whereas someone might have plenty of social contacts but might still feel pretty lonely. And so loneliness is also, fairly common overall. There was a recent meta-analysis based on data from over 100 countries, and they found that Northern European countries, the lowest prevalence rates were there, and the highest were in Eastern European countries, and for some age groups as high as over 20% of the population. Now, the research tends to show that the prevalence is higher among individuals who have problems with mental health, people who are objectively isolated, and then people experiencing chronic illnesses. And loneliness, of course, can have deleterious effects on physical and mental health. It can increase a risk of constellation of chronic diseases and the development and exacerbation of psychiatric disorders and suicidal behavior. And then meta-analyses also indicate that it increases risk of all-cause mortality as well. And so there's a range of unhealthy behaviors that loneliness is associated with that may be a pathway towards this contribution to premature mortality. And substance use appears to be one of these pathways as well. Now, the importance of social isolation and loneliness in substance use, I think have really been highlighted in some more recent high impact editorials and commentaries. And then, funny enough, the director of the National Institute on Drug Abuse, Nora Volkov, has been blogging about it for a while as well. So Bonnert and Ilgen in a New England Journal of Medicine editorial talked about social isolation often coming out of opioid use as a consequence. So there's these larger scale social determinants like lack of employment opportunities or socioeconomic inequities that can contribute to opioid use, which then contributes to isolation and depression. And then the overdose epidemic has further impacted communities because of fractured social networks and deterioration of social cohesion because people in the community are dying. And then Dr. Volkov has talked about social isolation and loneliness as both a consequence and an antecedent of drug use. And she's pulled from negative reinforcement models and incentive models of addiction. So basically, drug use can be reinforced through coping with social isolation, but then an individual using substances will find social contact less rewarding because of neural mechanisms being overwhelmed by the motivation for drug seeking instead. And then people with substance use disorders are then driven away from social interactions with others because of stigma too. And so you have this vicious cycle of loneliness and social isolation that lead to drug use, but then it contributes to further loneliness and stigma, thereby leading to more drug use. So it's important to be able to build in some abstinence potentially from substance use and drive up the incentive value of social interactions. And Venero and colleagues out of one of NIDA's labs conducted a series of animal studies with animal models of addiction that have demonstrated the importance of social interactions in reducing substance use. So they developed an animal model that allowed rats a choice between drugs, in this case, methamphetamine and heroin, and interaction with another rat through lever presses in one of these beautiful chambers here. And so what they found was that rats chose social interactions over heroin and methamphetamine self-administration in forced choice procedures, where they had to choose between either the drug or social interactions. And they did this in nearly every trial. And they were able to also characterize different levels of addiction based on animal models. And they found that this occurred, this choice of choosing social rewards over the drug occurred regardless of the level of addiction, as indicated by the overlapping lines in figure I. They also included studies of other manipulations, including delaying the social reward or punishing it through the administration of a shock with increasing intensity. And they found that the only times, these were the only times that were led to a relapse or like a reversal in choice, where they were choosing the drug over the social reward. So for instance, they didn't find a convergence of drug self-administration and lever pressing for the social interaction until the delay for the social reward was nearly a minute. And then similarly, they found that the shock had to get fairly intense before the rats lever pressed more for the heroin than for the social reward. And so these series of studies highlight the importance of social interaction and certain scenarios during which social interactions might not prevent substance use. And it also really builds on an older literature that indicated that rats raised in isolation are more likely to self-administer drugs than those raised in socially enriched environments, as there was a choice to pursue social interaction in these recent studies. So with this as some of the background, how does this look in people? And so overall, we find that loneliness is pretty common among individuals with substance use disorders. There was a study among a sample of individuals receiving methadone to treat their OUDs. They found that over 70% of women and over 2/3 of men reported moderate to severe loneliness. Loneliness and difficulty meeting abstinent friends is commonly cited as a reason for craving among individuals using heroin. And it's also often cited as a strong motivator for heroin use. And then it's also associated with this more severe clinical profile. So among individuals with substance use disorders, loneliness is associated with suicide attempts, more mood disorder symptoms, non-suicidal self-injury, and poor quality of life and life satisfaction. We did a survey, we looked at national survey data, and we found that individuals who had difficulties participating in social activities, this was more common among individuals with OUD compared to those without it. And then within those, among those within OUD, individuals reporting difficulties participating in social activities were more likely to report suicidal ideation than suicide attempts. In addition, studies among individuals receiving methadone for past heroin use, they found that loneliness was associated with worse sleep and greater pain severity, which of course are precipitants of relapse. And then there's also been some qualitative research that's underscored that some individuals with OUD indicate they lack purpose in life, and that's largely driven by a sense of loneliness. Now, loneliness also appears to be linked to social support and treatment seeking. Longitudinal research has revealed that the greatest reduction in heroin use was not just in people who were married, but those reporting a close personal relationship with their partner. So, it's not exactly loneliness, but gets more explicitly into the perception of their social relationship. And then individuals injecting drugs were 3 times less likely to seek OUD medications like buprenorphine or methadone if they lived alone. Treatment retentions associated with the perception of strong social support from one's family. Individuals using heroin who report being more socially disconnected also tend to believe that the harms of methadone outweigh the benefits. And then loneliness also seems to be higher earlier in recovery and also predicts a shorter length of stay in treatment. And so overall, these studies support that addressing loneliness in people with opioids can reduce risk factors for relapse or continued use and can have a significant positive impact on how a person develops, maintains, and utilizes social support, including treatment seeking. And so this leads us into our current study. So I want to take a second to explain about how we think about the relationship between loneliness and substance use. And I think it tends to integrate cognitive models of loneliness and negative reinforcement and incentive models of drug use. So there's this like interpersonal situation or context that can elicit cognitive biases. And these might include things like perceiving situations as being uncomfortable, distressing, or threatening. It might be expecting negative consequences from social interactions. It might be having biased memories towards negative social interactions. Could be, sort of hypervigilance to rejection. And then it might also be, using substances as the only and or most effective coping strategy. And so this is supported by research indicating that people who are lonely tend to pay more attention to negative social stimuli and find pleasant social stimuli less rewarding compared to people who are not lonely. And so this can contribute to things like substance use, avoidance of social situations, interpersonal conflict, behaviors that confirm many of the aforementioned beliefs. So for example, negative expectations of the social interaction might lead to relating to others in an anxious manner or pushing others away or being less responsive during interactions. And this can help confirm their negative expectations and beliefs. And then further highlighting behavioral impacts, people who are lonely are less likely to use strategies to regulate negative emotions. And so, emotional responses like sadness or anger or anxiety are often evoked from the counterproductive behaviors or cognitive biases. And so people who are lonely are often less satisfied with their social interactions and more often experience negative emotions from these interactions. These negative emotions can increase the incentive value of substances and decrease the value of other activities like, engaging in pleasurable social activities. And this can contribute to more substance use. And then because substance use is rewarding in part due to avoiding these negative experiences, exposure to or even anticipation of negative experiences can become conditioned cues to use the substances. And as a result, substance use is reinforced through the reduction of loneliness itself and or coping with cognitive processes like buffering from rejection or emotional reactions. And in addition to that, substance use disorders may perpetuate negative emotions, beliefs, and counterproductive behaviors, making meaningful social interactions just sort of more difficult to come by. So for example, someone might act aggressively when intoxicated, and this might lead to people not wanting to be around them, or like family members are consistently hurt with the actions of the person with the substance use disorder. And so as a result, there's this deterioration or avoidance of social interaction, social support might be eroded, and this is going to make sustained recovery more difficult. And then given the interconnection of these factors, a feedback loop is created, further driving loneliness and decreasing the quality and quantity of social interactions. Well, that's a lot. What the heck can we do about, changing this powerful downward spiraling? Well, there is some hope here. So there, in terms of addressing loneliness through psychosocial interventions, there was a meta-analysis on randomized clinical trials for loneliness that found that social cognitive training or cognitive behavioral oriented treatments significantly reduced loneliness to a greater extent than other loneliness interventions, like increasing opportunities for social interactions, social skills training, or enhancing social support. And then this was supported by another review that found that the main components of cognitive behavioral interventions, like cognitive restructuring, problem solving, exposure, and other modules, are helpful in addressing loneliness. So overall, we feel that more intensive cognitive behavioral loneliness-focused strategies are needed to address loneliness as both antecedent and consequence of substance use disorders. And as we looked through the intervention, we found one that seemed to be like, especially CBT. It had like the CBT greatest hits, basically, which I'll get further into in a second. So Call et al. Developed this 8-session CBT for loneliness intervention, and they found that it significantly decreased loneliness and social anxiety, and increased the quality of life at the 2-year follow-up time point. And essentially, this CBTL utilized strategies to directly intervene on a variety of the determinants indicated in the conceptual model that was depicted in the figure from the last slide. Call and colleagues are actually Swedish, and the delivery of the intervention was self-administered online. And so we translated the Swedish version of the manual. Unfortunately, between the Danish that I know and my colleague Nick Allen is fluent in Norwegian, we were able to make out most of the manual. I'm just kidding. We used Google Translate, and we were able to get the spirit of the manual out from that. I've been so aggressive with using that joke, and now I can't remember who I've told it to and who I haven't. So I'm sorry if you've been subjected to that joke again. But anyways, we used this translated version as our base manual. We incorporated relevant content from worksheets from a VHA brief CBT manual, and worksheets from the CBT SUD manual. And we met as a team and discussed ways to integrate the content into the CBTL manual based on our conceptual model, existing literature on substance use and loneliness, and other pertinent content from the brief CBT manual and the CBT for substance use disorder manual. And so the goal of our study is to assess the association of loneliness and opioid use by conducting a randomized clinical trial of CBTL in individuals with an OUD. And first, we are interested in assessing the impact of CBTL on loneliness. And we expected to see a decrease in loneliness to a greater extent in the CBTL condition compared to the control. And then we are also interested in seeing how changing loneliness may impact the trajectory of opioid use. We expected there to be a decrease in opioid use after receiving the intervention, and we expect this to occur through reductions in loneliness. And I'll take you through the design and methodology. So basically, we post advertisements on meta platforms like Facebook and Instagram, and direct people to a study page where they can enter the contact information, and we reach out to them and assess their eligibility. And participants need to be English speaking, at least 18, have access to a phone or internet, and then screen positive for at least moderate opioid use disorder on a structured clinical interview. And they need to score at least a 13 on the NIH loneliness scale, which is 1 standard deviation above the mean. And then additional exclusion criteria include severe cognitive impairment and individuals who are currently experiencing severe withdrawal. And we are planning on enrolling and randomizing 125 participants to either CBT for loneliness condition or the health education condition. And we have assessments at baseline after the consent, and participants are compensated $40 at this point. We have a mid-treatment assessment, which is done after session 3. And participants can earn $20 for this mid-treatment assessment, but they're also eligible to earn a $20 bonus if they complete 3 sessions within 4 weeks. We included this to enhance the treatment retention. And then after 6 sessions, they complete a post-treatment assessment and an exit interview where they can provide feedback on their experience of the intervention. And they receive $40 for this post-treatment assessment. And their participation is rounded out with a 1 and 2 month follow-up where they can earn $30 for each assessment completed. So basically, participants are eligible to earn up to $180 for participating. And then I'll get into some of the measures as I go through the baseline characteristics. So I'll get into both of these in a bit more detail in just a second, but basically participants are randomized to receive either CBTL or the health education. These are delivered by the same group of study therapists. Both are 6 45-minute weekly sessions. The control condition helps account for non-specific conditions. These are things like providing attention or contact by the study therapists, providing support or building rapport, and then managing participants' expectations of the treatment outcomes. You know, for the most part, we think that the health education condition is inert with respect to the outcomes of interest, but should help to sort of maintain engagement. And we also believe that it decreases the likelihood of participants feeling marginalized because they're actually, receiving potentially relevant educational content that facilitates an issue-oriented focus. And based on our exit interviews, we think this sort of bears out fairly well, fortunately. So for CBTL, the treatment starts off by just sort of get to know the person, how long they've been using drugs, how long they've been lonely, when it was most severe, what their treatment history is like. And then there's just some education about the CBT model and how loneliness and substance use fit in there. It's really laying the foundation for the rest of treatment, essentially. And then also complete a functional analysis at the end of the session to help piece together triggers for their loneliness and substance use, and also helps sort of generate awareness of connections between events, thoughts, and emotions. And then sessions 2 and 3 get more into the specifics regarding cognitive distortions and automatic negative thoughts that contribute to the loneliness and substance use. So some of these thoughts might be like the only thing I can do to deal with being alone is to use my substances, or I have to hide my substance use from my family or people I know, or it's a waste of time to talk to other people. I have to use when I wake up in the morning. No one wants to talk to me. And so we help the participants identify these types of thoughts. We help them link this to their emotions, and then we help them generate more helpful, balanced, and accurate thoughts or alternatives to these. So, last time I called my daughter and she talked to me, or I actually enjoyed talking to some people from time to time. I have other things I can do rather than use substances in the morning. And then also to really drive these home, and help them in identifying these automatic negative thoughts or cognitive distortions. We provide them a list of cognitive distortions where they can kind of label, where they can label them. So, things like all or nothing thinking, or minimizing, or magnifying, or personalizing, and a variety of others to again, help them identify these negative thoughts that are keeping them stuck in their loneliness and substance use. And then sessions 3 and 4 are the be heavy sessions. This is where we're really focused more on the behavior. And in these sessions, we help the participants generate some activities that they can do, particularly those that are socially focused and that don't involve drug use. These have been a range of activities like going out for coffee or lunch with a friend, simply calling someone, spending more time with parents. And for some, it's just been, getting out of their house and doing something else. And basically we extend this into the following session, but the following session maybe has like a little bit more of an emphasis on exposure specifically. We provide some education on avoidance and how exposure to, the anxiety or distress or discomfort from the activity can help overcome it. So we'll also sort of capitalize on their successes from the previous session and other things that we've picked up on as astute therapists of how exposure to things that they've been avoiding has allowed them to experience these activities with less distress over time. And we'll continue to tackle these activities that they've identified in a systematic way by trying things that they've identified as being at least moderately distressing, and staying in that situation until they notice that the stress is diminished. And then in the last session, we are, we're really pulling it all together. What did you learn? What do you want to continue working on? How can you accomplish this? This is what I noticed as your therapist. And then the therapist helps them identify warning signs that they might be sort of headed back towards the things that they had been doing that kept them in this loneliness substance use cycle. And the therapists work with them to identify ways to address these warning signs, mostly through reinforcing the strategies that they've learned over the course of the treatment. For the health education, there's some discussion involved to keep people engaged, but the therapists are really directed to steer away from engaging in any of the cognitive restructuring or behavioral activation techniques used in CBTL. And so it focuses on these areas like stress management, healthy eating, exercising, smoking and alcohol use, sleep hygiene, and maintaining a healthy lifestyle. And primarily the content is about what they know about this area, what they've done in the past, different things like that. So for the analyses, we're going to be underpowered for most of this because it's a pilot study, but we'll have this set up for our larger trial, and essentially we'll be using mixed regression modeling to assess condition, time, and condition by time interactions as predictors of loneliness and opioid use. And we'll employ a Bonferroni correction to account for multiple outcomes. And then we'll do a mediational analysis to assess if there's reductions in opioid use through a single variable like loneliness, or through a chain pathway like changes in loneliness lead to reduced depression and anxiety, and thereby reduce opioid use. So in terms of how far we've gotten as of Monday, we've screened almost 150 people. We found that 66 weren't eligible. Most of the people aren't eligible because they don't have an opioid use disorder. But the majority of the time, it's actually because they're not using opioids and they're actually using another class of drugs, like cocaine or alcohol. And then a smaller percentage are either, in long-term recovery and thus haven't used for a long time, or they're using prescription opioids and they're using them as prescribed. And so far, we've had the opportunity for you math wizards who were able to calculate this before, but we've had the opportunity to enroll 62 people so far. And we've had excellent study retention. We've lost just 5 people to follow-up so far, and things are progressing pretty nicely. So we've done 46 mid-treatment assessments, 38 post-treatment assessments, 31-month follow-ups, and we've had 29 people get through the entire study. So we haven't, as I mentioned in the beginning, we haven't run any formal outcome analyses, but I just want to present some data on our sample to date, and I'll highlight some of the interesting pieces here. So surprisingly, we've had 2/3 of the sample is comprised of women, which is a bit overrepresented compared to the opioid use disorders overall. And we found we've enrolled a little over 1/5 of the sample is Black or African American. Our Hispanic or Latino or Latina samples is a bit underrepresented, as we've had just 10% of the sample. We have about 30%, 37% who are living alone, and nearly half have never been married. And the level of education and percent with at least part-time employment were a bit, maybe higher than we expected at 33 and 56% respectively. We have about 1/3 of our sample of reported lifetime injection drug use. About 1/5 had received substance use disorder treatment within the past year. And typically this is methadone or buprenorphine treatment. We used the inventory of drug use problems to assess consequences of substance use. And the mean score of about 38 is comparable to other studies of patients in substance use disorder treatment. We use the timeline fallback method for substance use. We examine their substance use in the 60 days leading up to baseline. And opioid and substance use more broadly is frequent, is very frequent in the sample. So we're finding that on average, the sample was abstinent on less than 10% of the days in the past 60 from any substance, and less than 20% from any opioid. And then we actually found that 61% of the sample used opioids every single day, and 78.9% used any substance every day. So overall, we feel pretty good about recruiting and enrolling a sample with sufficient substance use and substance use severity. In terms of some of the social related constructs, we use the UCLA loneliness scale to assess loneliness. We found a mean score of nearly 56. So just to give you a sense of what that means, the scale is from 20 to 80, and higher scores indicate higher loneliness. So essentially, and it's 20 items. So on average, participants are indicating that they're experiencing nearly every statement at least sometimes. And then we use the 12-item interpersonal needs questionnaire to assess perceived burdensomeness and lack of belonging, two key constructs that contribute to suicidal thoughts. And the scale ranges from 12 to 84, and it contains items like people in my life would be better off if I were gone, or I feel disconnected from other people. And we found a mean score of 49.7. So there's some substantial endorsement of feeling of our participants feeling like they're a burden on others and that they don't belong. And we use the Duke Social Support Index to assess social support, and scores range from 7 to 21, with higher scores indicating more social support. So a mean score of 11 suggests a pretty low level of social support. And so again, it looks like we are getting people who are lonely, who have issues with social support, So, again, there's something that we can potentially change here. In terms of some other clinical characteristics, a little under 40% have received some kind of mental health treatment in the past year. We administered the PROMIS profile, and for the most part, the sample had one standard deviation above the mean for each of the components. So we found the sample to be on average, moderately depressed, moderately anxious. They had a moderate level of pain interference in activities. There was a moderate level of fatigue. Their physical functioning was moderately impaired, and there was reporting of some mild sleep disturbance as well. So again, we don't have the outcome data, and a lot of these interesting themes have just sort of emerged through exit interviews and when discussing things in supervision. And overall, it appears that people seem to be engaged in the treatment. They find it to be useful. We seem to be addressing an important need for people. Recruitment has been great thus far, knock on wood. And had it actually been not for the capacity of our therapists to see more people, we easily could have ramped up recruitment even more. So like we've been using a relatively low budget on Facebook for the recruitment. Ultimately, though, based on their substance use and the social factors and other clinical characteristics, and frankly, the level of treatment engagement, we feel like we're reaching our target group. And as I just mentioned, we're sort of pleased that we're reaching people who aren't necessarily in treatment. We really think that increasing people's connection to others is going to ultimately also lead to a bridge to other treatments as well, whether it's to get them linked with medications for opioid use disorder, or to deal with people's lifelong trauma that they've been experiencing, or other types of treatment. While we have gotten good feedback that people seem to like the treatment, we've also heard from both the participants and therapists that they thought that the treatment could be a bit longer. So when I initially proposed this intervention, it was proposed as a 4-session intervention. And as I was putting together the manual, I was thinking like, there's just way too much information packed in here in just the 4 sessions. And, we're starting to see that it's still pretty brief, and we'll plan on pushing this out to more of like an 8-session intervention in our next iteration to NIDA. We've also already proposed this as an 8-session intervention version for the VA, and have been delivering it as an 8 intervention for another study for veterans reporting suicidal ideation. Pain has come up a fair amount in this trial. So many people have debilitating pain that's also exacerbated by their prescription opioid misuse and isolation. And so we're interested in looking into exposure to movement and addressing some of the pain-related cognitive distortions to assist with decreasing loneliness among individuals with chronic pain. And as I commented earlier, there certainly appears to be some of those themes of substance use being both an antecedent and consequence of loneliness, creating this vicious loneliness substance use cycle. This seems to be pretty illuminating, I think, for a lot of our participants. It's sort of the first time they're seeing how thoughts and emotions are connected and how these can contribute to their substance use and loneliness. They might be realizing that some of their avoidance is due to these powerful negative thoughts that have just been sort of accepted to be true, even though they may not be. And, they're attempting to think about situations in a more helpful way while not dealing with them through using drugs in many instances. So we've had, I think we've had a lot of exciting developments on it that so far, and several more that are upcoming, and some related offshoots. So first, what this 50% enrolled was actually supposed to go up for June 1st, but we actually ended up meeting this, probably actually maybe even today. And so we're excited about, we're about a month and a half ahead of schedule here, which we're really excited about. We'll be starting a VA Health Services Research and Development pilot in just a couple days. And this study utilizes a similar manual, but it's undergoing, maybe some, even more rigorous refinement. We've really beefed up the manual relative to the 6-session version, and we're going to be integrating some additional information on substance use disorders. Some key differences is that we'll be doing an 8-session version that I've sort of hinted at, and then we'll also be recruiting for substance use disorders more broadly. So basically, the way that we're thinking about increasing the number of sessions from 6 to 8 is to have a problem-solving session as a standalone. And then we've also included a communication session where we go through assertive, aggressive, passive, and passive-aggressive communication style. Now, with this study, we're looking forward to seeing this with the sample beyond just those with an opioid use disorder, because we feel like it can sort of generalize more broadly to other substance use disorders as well. And also, it's just sort of, it's difficult to stomach turning people away from the study who are struggling with substance use and loneliness, but aren't using opioids, so they don't qualify. And it's another reason why it's tough to swallow when people have chronic pain and are taking opioids as they should be, but are lonely and they're excluded because they don't have an opioid use disorder. And so we also have another VA grant that should be, we should be getting our scores back any day now, actually, that's going to look at pain and loneliness more. Starting in June, we'll actually be having 2 NIDA summer internship research program interns joining us remotely, but as part of the study. So Ethan Dennis will be going into his senior year, and he is from the University of Arkansas, and Matthew Snyder's from Syracuse University, and he'll be going into his junior year. And this program supports undergraduates with a focus on increasing underrepresented populations in drug abuse and addiction research. So we're really excited about this. They seem to be extremely bright and motivated. I was just joking that they are, way further than I was at their, when I was an undergrad. So they've identified some areas of interest, and I'm essentially going to try my best not to drive them away from this field of research. So they'll be joining us for 8 weeks, and their time ends with a presentation to our research team and to other people in the internship program. And later this summer, we're also looking to submit a related NIDA R34. So for those of you who don't know, R34s are planning grants to encourage pilot work and preliminary support for large-scale trials. So there was a request for applications that came out where it focuses on enhancing social connectedness and ameliorating loneliness to prevent and treat SUD and to support recovery. So NIDA, I'm your man here. So I appreciate NIDA putting this out. And we're in the early stages of this study, but we're considering how to increase the research on substance use and social connection in Black and African Americans. And we're interested in using this R34 to look further into this. So, the application's due in a couple months. So we're looking forward to working on that a bit more. And again, because we think that decreasing loneliness can help people get into other treatment, we're also hoping to decrease some issues with health inequities. By September, we're hoping to be, continue our recruitment at a decent clip, and we're expecting to meet our 75% enrollment target at this point. In October, we'll submit the R01 for this study, or that large scale full efficacy trial. We obviously won't be done with the study, or we'll have looked at the outcome data, but we'll be able to present data similar to what I presented today to show that we're able to execute the study. We seem to be reaching our intended audience. They seem to like it and gravitate towards it, and maybe even have some practice with recruiting a more targeted sample based on some additional recruitment tweaks to increase certain groups that are comprising our sample. So, because NIDA just came out with this R34 mechanism, which again is basically to provide preliminary data for an R01, we're almost a year into our pilot grant already. We think that we will be in really good shape for both this R34 and the R01. And then by February, we are looking to have our entire sample enrolled, and the study will wrap up our final 2-month follow-up in May. This was a templated timeline, and my head almost exploded just trying to add one other time point. So I didn't get a chance to add a 9th time point. That would basically be the resubmission of the R01 in July 2023. But who knows? Maybe we don't have to do a resubmission, just fund it on the first shot. And then before I close, I just want to take a second to acknowledge my team. We have a great team to help execute this project and our upcoming VA one. I couldn't do this without my coordinator, John, who, in my head is like this octopus with 8 arms reaching out to participants and coordinating schedules with therapists. Also, this was my first funded grant and my first project out of U of R, and Tammy Belinsky was instrumental in helping me get this up and running, catching John up to speed while also helping participants through the process. Dr. Stecker and Allen make up the investigative team. Dr. Stecker is from the Medical University of South Carolina, and Dr. Allen is from Ohio University, soon to be Ohio University. I refuse to say the Ohio State, so I won't go blue. They're both investigators with me at the VA Center of Excellence, and we have a great set of study therapists, including postdocs from the COE, U of R psychology doctoral students, and a psychology doctoral student from Syracuse University. So hats off to them and all their work on this. And then Park Bogan is coordinator on the VA side, and Dr. Steve Maisto from Syracuse University has joined us for the VA study, and his feedback on the manual has been valuable. So that's all I got. Thanks.
Okay, thank you, Lee. It's very interesting, and certainly look forward to hearing what you find when it's all said and done. So we have at least one question so far. This one's from Kim Van Orden. And she asks, in my work on treating loneliness, I found that many people do not identify as lonely, even if they score very high on a validated loneliness scale. For this reason, in my treatments, we do not use the word lonely unless participants prefer it. How do you handle the stigma of loneliness in your trial?
Yes, great question. Kim, I remember we talked about this, and it was something that I was very aware of. So in our recruitment, we don't use the word lonely. After we had that conversation, I also changed the consent to kind of avoid using the word lonely. But with that being said, when we administer the NIH loneliness scale, I think one of the items asked directly, like, I am lonely, like one of the statements is I am lonely, and people seem to be endorsing that just as highly as some of the other ones that kind of get around it. But ultimately, even in the as we go through the treatment manual, we don't necessarily we take their lead in how they describe it. So if they said like I feel alone or I feel disconnected, we'll use their words. If they use lonely though, we'll go with that. If we end up bringing it up and then they start to use it as well, we'll go with that as well. But that was a great piece of advice. I really appreciate that.
All right, we have another question. And this one is, for the patients who finish the 6 sessions, are you measuring whether they remain in their less isolated state and for how long? Just wondering about the longer term impact of this intervention.
Yeah, so unfortunately, we assess it at each of the time points, and we'll know, like, the change in their loneliness and some of the other like social support and the quality and quantity of social interactions that they have from, changes from baseline to post-treatment, and then as far as the 2-month follow-up. So we'll get some indication of, how much and to what extent their feelings of loneliness are maintained out for 2 months. So we'll kind of see there, and then for our larger scale trial, we'll do time points that are further out as well to see how they kind of maintain. But it's another reason why I think like also having them get into treatment, like it helps. It may help get their foot in the door to other treatment, and if they're able to get engaged in like medications for opioid use disorders, then that might be something that can kind of bring out the decreased loneliness and social isolation. It can live beyond the treatment essentially.
Okay, we have time for one more very fast answer to one last question, and that is, how efficacious do you think this would be with methamphetamine?
It's a good question. We're hoping to learn a bit more about that in our VA trial, where we're recruiting people beyond just opioid use disorders. I've also heard someone from the University of Washington talk about how critical it is to be able to establish and maintain some pretty powerful social support for people with methamphetamine specifically. And so this might be one potential way to do that can kind of supplement something that beyond just a standard CBT for substance use disorders. We're really like the emphasis and focus is really on the social aspect for them. So my hope, we think that this will generalize to other substance use disorders as well. We're sort of at the really early stages of this though still.
All right, well, thank you, Lee. Those are good answers, and thank you for the people who submitted questions. This is really interesting work. So, and it's more and more needed all the time, given how things are going. So look forward to hearing updates, and I want to thank you again for presenting this year and today.
Yeah, next year I'll come back with the outcome data and stuff.
Yes, okay, well, we'll hold you to it. All right, so thank you again. Thank you everybody for joining today, and we'll see you next month.
Thanks.